Welcome back to Med Weekly. Now today's topic is rheumatoid arthritis, which is commonly referred to as RA. This autoimmune disease typically affects 0.5 to 1% of the population and commonly affects women and the elderly. Now today we have the privilege of being joined by Amanda, an EIRA representative from Sweden, and Poppy, who's also a rheumatoid arthritis specialist. Thanks for being with us, guys. Now, Poppy, could you explain to us what exactly rheumatoid arthritis is?
Rheumatoid arthritis is a chronic inflammatory autoimmune disorder. It's a debilitating disease hallmarked by symmetric joint inflammation resulting in cartilage and bone damage and causes varying degrees of pain and stiffness. While it most commonly affects the joints, it's a systemic inflammatory disease affecting all parts of the body. Extra-articular manifestations include rheumatoid nodules, pulmonary involvement, vasculitis, cardiac disorders, and the list goes on.
So Amanda, what characterises autoimmune diseases?
Well, essentially, what occurs in autoimmune disease is that the body launches an immune response against itself. In RA, this process involves a complex interaction between genetic and environmental factors, triggering a repeated activation of innate and adaptive immune responses. There is abnormal activation of T and B cells, and there are certain autoantibodies that we think are important in developing RA. In the joint, you get synovial membrane hyperplasia, cartilage and bone destruction, and then you have swollen joints with stiffness, pain, and eventually deformity. Two main autoantibodies that we use for classification are rheumatoid factor and anti-citrullinated protein antibodies, or ACPAs.
And how and why does this actually happen?
You tell me that, Simon, and I can go home and retire.
Well, moving on, one of our viewers, Mary, has just tweeted in, and she says, "I'm 37 years old and have just been diagnosed with RA. My good old Dutch mother suffers from it too. Do you think I inherited it from her?" Could you help Mary answer this question for us, Poppy?
Yeah. So we know that there are genetic and environmental risk factors which may be involved in triggering this autoimmune response. In terms of genetics, it's likely her family history played a role in her own development of RA. In fact, a positive family history increases a patient's risk by 3 to 5 times, with a high heritability rate for seropositive RA.
And so what exactly is seropositive RA?
So that's the classification that Amanda referred to earlier. Seropositive RA means there's rheumatoid factor in the patient's blood. So sometimes the presence of ACPA is also counted as seropositive. The alternative is seronegative RA, which lacks these autoantibodies. So in regard to Mary's question, genetics account for an estimated 20 to 50% of the risk, depending on the classification.
Right. Well, when I was researching for this segment, I came across an article from 1987, and it talked about the shared epitope hypothesis. Could you explain this paper and where the knowledge on genetic influence is at today?
Yes, that'd be the Gregerson et al. Research paper. So the shared epitope hypothesis is based on the assumption that MHC class II molecules are directly involved in the etiology and pathogenesis of RA. The MHC class II molecules on antigen-presenting cells bind the epitope of an antigen and are encoded by a complex of human leukocyte antigen, or HLA genes.
Well, the paper also stated that genetic variability in HLA-DR is thought to give rise to different functional units, or epitopes, which may affect antigen presentation and immune regulation. And 70% of RA patients actually express a risk allele, the so-called shared epitope, or SE, compared with only 28% expression in the undiseased population.
Actually, a meta-analysis that we published a few years ago supports this HLA-DRB1 hypothesis, where we also identified the risk allele PTP22 that seems to play a role in developing RA. We even saw that these two genes might interact to multiply the increased risk.
That's right. Polymorphisms in PTPN22 seem to be implicated in RA as it produces an inhibitory action on regulatory T cells. This suppresses the immune response, ultimately allowing the inflammatory response so characteristic of RA. Moreover, in seronegative RA, there seems to be a larger influence of HLA-DR3 genes as opposed to DR4. I'm actually only including the major genes identified that have the strongest links to RA development. There seems to be a huge interplay between other gene loci and genetic variations between RA classifications. So currently, there's significant difficulty determining exact susceptibility genes and their relative risks.
Well, it looks like Mary might have inherited some RA susceptibility genes, but there are a number of environmental factors that could have contributed as well, aren't there?
Yes, definitely. There is literature suggesting that sleep deprivation, shift work, microbiome composition, nutrition, geographic location, ethnicity, hormones, and tobacco smoking may all be important to the risk of developing RA, but some risk factors have stronger evidence behind them than others.
You mentioned hormones. Is it likely that this is the reason for more women than men having rheumatoid arthritis?
Well, it is one of the main hypotheses explaining the gender difference. Estrogen, some androgens, and prolactin have all been proposed to be of importance. Estrogen and prolactin are both pro-inflammatory hormones, and the increased exposure in women may, in part, explain the high female-to-male ratio.
Now, most sources state that the main environmental risk factor is smoking. In fact, we have a tweet from another viewer, Claire, and she says, "I have been a smoker for most of my life. Will I get rheumatoid arthritis?" Poppy, how would you answer this?
Well, smoking does seem to increase the relative risk of RA, but the absolute risk is actually quite small. The exact effect of smoking is not confirmed, but it may interact with age and gender-related biological factors. Much evidence also points to a genetic smoking interaction.
So Amanda, EIRA has done a lot of work on the interactions between genetic and environmental risk factors. Could you tell us a bit more about that?
Of course, Simon. So this is actually a focus point in our labs. When we look at interactions, we must separate additive and synergistic risks. A big study we published in 2004, we looked at smoking and HLA-DR shared epitope genes as an example of this. Never smokers with SE genes had a 2.8 relative risk. Current smokers with SE genes had a relative risk of 2.4. So if these factors were merely additive and not synergistic, a smoker with SE genes should have a relative risk of about 6.2. In our study, smokers with a single SE allele had a relative risk of 7.5 and smokers with a double allele 15.7. So these results do suggest that there is an interaction between smoking and these HLA genes.
So we can only hope that Claire doesn't have the double SE gene.
Well, yes, but there are many things to keep in mind here. The absolute risk is still small, and also these relative risks were only increased in RF0 positive RA. The contributing factors of seronegative RA are much less well documented. The study included many different ages and both men and women. Some previous studies have shown that smoking increases RA risk only in men. But I don't think that evidence holds anymore. Our study, the Nurses' Health study, and several other studies suggest that smoking is a risk factor in women too.
Another limitation is that many of these studies on risk are epidemiological and only report associations. We still know very little about risk mechanisms. In 2006, a study actually reported a 21-fold increased risk in ACPA-positive smokers with double SE genes. They suggested that smoking is only a risk factor for ACPA-positive RA because the smoke induces citrullination of antigens in the lungs.
Yes, that is a fairly widespread hypothesis. In the meta-analysis I mentioned before, we saw the same pattern, with evidence of interaction between smoking and the SE genes in ACPA-positive RA, but no apparent interaction between smoking and the mutated PTPN22 gene allele.
Now that's actually pretty confusing, so would you be able to explain that in more simple terms?
Yes, Simon, so what that means is basically that we know that a few things do something together and or independently, but we don't really know what anything does.
Well, let's take a look at ASFA's expert interview to see if it can provide us with any answers.
Hi, I'm Osma and I'm here with Dr. Catherine Bryant, who's a researcher at UNSW, researching rheumatoid arthritis, and she's based at Liverpool Hospital. So basically, I wanted to ask you that we have a case of a 37-year-old Caucasian woman, and she's got rheumatoid arthritis. So how would genetic factors have contributed to her getting this condition?
Broad question. Rheumatoid arthritis is a very heterogeneous disease, phenotypically, and there have been a lot of genome-wide association studies have been performed that include large numbers of patients and controls. And so what has come out of these studies is basically there's no one gene that's involved in rheumatoid arthritis. What is thought it's a whole multitude of genes. And then there have been many SNPs, single nuclear polymorphisms, identified in these loci, and actually over 1 million SNPs have been identified, okay? So there are genetic factors involved, but then trying to find out which are the important mutations and in these loci, that is a really taxing job. At this stage, apart from the HeLa and the MHC class 2 molecules there at that loci, that has a very strong association with rheumatoid arthritis, but it's not the whole story. Okay.
All right.
There are a lot of environmental factors that are involved. For example, one big environmental factor is smoking. Causes citrullination of various proteins. So that's the conversion of an arginine residue to a citrulline residue. And antibodies are formed against that protein because it's not self, basically. So smoking is a big environmental factor.
Which one would you, how would you figure out which ones are contributing in terms of how much? Would you say genetics play a bigger role or environmental?
That's really tough because hereditary-wise, for example, it's only about 60% hereditary. I think it's a mixture of both. We don't know.
Okay.
Yeah.
Thank you. So, okay, now back to you, Simon.
Well, we're going to have to wrap up the show for now, so thank you for both coming in and sharing your expertise. We hope that we answered at least some of your questions this week, but join us next week where we discuss a topic that's even more confusing, if that's possible. So bye for now.